Hey, how are you? My name is Austin. I was the CRNA taking care of Miss Jane Doe. If you're the nurse that's going to be receiving Miss Jane Doe, I'd love to go ahead and give you a report if you're ready. All right. Well, if you're ready, I'll begin. This is Miss Jane Doe. She's an 80-year-old female. She has a past medical history of coronary artery disease, hypertension, hyperlipidemia, renal insufficiency, atrial fibrillation, and degenerative joint disease. Her surgical history includes a CABG in 1977, bilateral cataract removal, and hysterectomy with no significant anesthetic history. Miss Jane Doe presented for an elective repair of a type 4 descending thoracoabdominal aneurysm and underwent general anesthesia, in which we placed a 37 French double lumen tube without difficulty via direct laryngoscopy technique. We placed a 14 gauge in the left AC, an 18 gauge in the left upper extremity, a right radial A line, a left fem A line, and a right IJ introducer with a pulmonary artery catheter locked at 48 centimeters. We also placed a lumbar drain. Throughout induction, there was a 20 to 25% reduction in systolic pressures that required an 80 microgram bolus of phenylephrine. Overall, the patient's vitals were stable and required small doses of phenylephrine and ephedrine to increase blood pressure. There was an increase in systolic pressures to 144 millimeters of mercury after aortic cross-clamping, in which I gave 50 mics of nitroglycerin. After surgical closure was completed, there was a rise in systolic blood pressure to 130 millimeters of mercury, and metoprolol was administered in increments to total 10 micrograms. Propofol was also started at 20 micrograms per kilogram and titrated between 20 and 40 micrograms per kilogram for post-operative tolerance of the endotracheal tube. Throughout transport to the CTICU, systolic pressures were maintained between 115 to 120 millimeters of mercury. The patient was given a total of 3,600 mLs of crystalloid, 750 mLs of colloid, 3 units of packed red blood cells, 855 mLs of autologous cell saver, 463 mLs of FFP, 30 milligrams of protamine prior to closure, and 1,000 micrograms of fentanyl. For output, there was 680 mLs of urine, 2,100 mLs of blood loss, cerebrospinal fluid drainage of 120 mLs. For most recent labs, there was a hemoglobin of 11, hematocrit of 32.8, platelets were 91,000, the BUN was 20, and a creatinine of 1.1. The plan for post-operative treatment is a MAP greater than 80 to maintain cerebral perfusion pressure greater than 60. We'd like to keep the patient intubated overnight on 40% of FiO2 as allowed and a PEEP of 8. The plan is to wean to extubate per cardiothoracic surgery approval and hemodynamic stability. To prevent excess cerebrospinal fluid drainage, I suggest keeping the patient supine and limiting movement until the lumbar drain is removed. I also recommend consulting physical therapy and occupational therapy upon extubation and lumbar drain removal to increase patient mobilization and assist with their activities of daily living, especially with their history of degenerative joint disease. Due to the patient's history of renal insufficiency, a nephrology consult may be necessary, especially for a high risk of acute kidney injury. I also recommend a neurology consult if there are any deficits from possible spinal cord ischemia. And if you don't have any more questions, that will wrap up my handoff. And I wish you nothing but the best. That goes for you and Miss Jane Doe. All right, you have a good day.